And we're live. Welcome to BSG Live. Are you curious about how doctors invent new things? Well, I'm joined with Dr. Susan Pannullo from Weill Cornell Medicine today to show off her latest invention that's designed to help military service members and other people who have suffered severe skull trauma. We're going to look at this device. We're going to talk to her about the inspiration for this innovation, and we're going to get into the details of how she brought this idea of hers to life with a team of inventors and inventor supporters at Weill Cornell Medicine here on BSG Live today. So let's go ahead and get Dr. Pannullo here with you, or with us all. Dr. Pannullo, we are live and welcome. How you doing this morning?
Hi, Dr. Radwanski. Thanks so much for having me here. I'm really happy to join you.
It's my sincere pleasure. My sincere pleasure. So obviously it's noontime. I'm sure a doctor's day is not starting at noon, and this is not the first thing you're doing today. You know, what other kind of things have been going on in the life of Dr. P? And
Well,
Carlos, can we go ahead and get the names put up on the screen when we get a second? That way our audience can keep track of everything. So what have you been up to today, Dr. P?
Well, my morning started kind of usual at 5 o'clock this morning with a cup of coffee and a drive out to New York from my home. And I did cases on the Gamma Knife, which is a device that we use to do
Gamma Knife. Sounds fancy. Sounds
it's
fancy.
It's very great for patients. Outpatient procedure, really very, very comfortable and very gratifying for patients to undergo that type of treatment. From there, I came down here. I have patients, procedures, and am ready to enjoy my time with you.
Great, great. So, you know, obviously, BSG Live, we've got tons of audience members that are not doctors. So my job, as always, is to really break things down, help people understand the conversation. So I know we want to get into this device that you've invented, but just to keep the audience sort of up to date and, you know, informed, you know, you mentioned Gamma Knife. It sounds really cool. Obviously, one of the many gadgets that I'm sure a neurosurgeon plays with on a daily basis. Do you want to take a minute just as like a side note and kind of explain what Gamma Knife is to people out there who are not doctors?
Absolutely, I'd love to. So Gamma Knife uses a little tiny beams of radiation to do things that back in the old days we used to have to accomplish by cutting a patient's skull open and going inside. Now, over several years, have been multiple emerging technologies. One of the most commonly and most promisingly used is called Gamma Knife, which is essentially a technique to use these very tiny beams of radiation to attack or damage or obliterate a target inside of the head without actually opening up the skull. So the patient doesn't need to be hospitalized. The patient can come in and out as an outpatient. And at the very most, it requires local anesthetic. In most cases, actually, that's not even needed. And we position the patient in a breathable plastic face mask for their procedure.
Wow. Yeah, that's it's pretty cool technology. I can't say I have a robust experience with it, but you know, we did from time to time have to help out with getting patients positioned in the pinning frames that you alluded to. You need some local anesthetic to get put on. But I guess you guys aren't even always using that now.
Correct. Sometimes we do need a positioning head holder to keep the patient in the right position, but many times we actually use a breathable plastic face mask instead. In any case, it's a very comfortable procedure for the patient and has an extremely high success rate and very low risk of complications.
Wow, that's awesome. So that's obviously a really exciting, kind of interesting piece of technology that, you know, is a big part of a neurosurgeon's arsenal. And on that note of, you know, technology, you know, the focus of today's show is really talking about creating new things, you know, inventing new things. I was watching this clip from Elon Musk, and somebody said, "Oh, you're such a great businessman." And he just looks at me, he goes, "I'm not a businessman." And I'm like, "Well, what are you talking about? You're like one of the richest guys in the world. You're the richest guy in the world." He goes, "Oh, I consider myself more of a technologist," which I thought was a very fascinating way to put things. So let's why don't you go ahead in your own words or your own sense? How do you describe this new device that you recently developed? I have the video. We're going to look at it so people can really see what it looks like. But I kind of just want to hear you describe it. I want to, right from the inventor's mouth.
So I think the best way to go through this is to describe the story of what happened and what provoked this answer to a problem that we saw in a patient. As many medical inventions happen, often it comes out of necessity, the need to serve a patient who has some sort of problem for which there's not a good solution. So in this particular case, a patient of mine had surgery for a tumor, luckily a benign tumor in her head, and had a piece of her skull removed for that surgery. And that's the way that in regular open neurosurgery we do things. The piece of skull was put back and the patient recovered nicely from the surgery. However, the patient ultimately had an infection of the piece of bone, which is not really a completely uncommon occurrence for patients who have a piece of skull taken out and then removed. And so that piece had to be removed again in a second procedure, and this time left out of the head, again, which is kind of standard fare for when that type of situation happens. So we had this patient with basically a hole in her skull. And usually what happens in those cases is the patient will be instructed to wear a helmet to protect the area of her head that's vulnerable to any insults or anything that could happen in the hole, because now there's no protective skull in place. So it happened that this patient one day was sitting on the couch with her daughter waiting for several weeks, which is often the case, waiting several weeks for replacement of the piece of bone while the infection was cured and everything was healing up. And in that time, she was, I remember watching TV with her young granddaughter on the couch, and the two of them were having a great time. And I guess the granddaughter's elbow somehow went into the place where just that hole happened to be. And of course, it scared the granddaughter, it scared the patient. She was okay, but she really realized at that point that she was vulnerable, even at a time where she was doing something like sitting on the couch without her helmet. And so it provoked a conversation with us about what to do. And we wound up, me and a team of engineers who I work with very commonly, on creating some sort of device to protect her. We used her scans to customize and 3D print a cover basically for the hole, and ultimately used a team of Broadway wig designers, because she had friends in the Broadway wig industry somehow, to
So
create.
the friends from the Broadway wig industry were the patient's friends.
Yes, the patient's friends were pulled into the
Wow.
situation to help us have a way to secure this device, this little thing that we had made, almost like a sewer cover on the street, a cover to go over the hole and kind of go over the edges of it so that she could be protected from further elbows or other things that might happen while she waited for this second surgery, or actually third surgery, to happen. So we manufactured this device. The Broadway wig designers came in and helped us to create a way to keep it in place under a wig. As it happened, she had a family event to go to and didn't want to go with something, kind of wrapped around her head. So it was embedded in a wig and actually worked very nicely, to the point where the patient has not yet had that surgery. This is years and years later, but she was so happy with this and was so concerned about having surgery again that she's left this device in place in a wig that she wears under the wig when she's going out, under a variety of other covers like a skull cap when she's in the house. But it occurred to us at that point that this type of solution might be applicable in other situations. So fast forward to more recently, I teach a course in biomedical engineering on the Cornell Ithaca, New York campus, where you spent a lot of your time. And with
We
this,
both did.
yes, we did. And
We
with
both did.
this, with this group of engineering students that I teach, we worked on a project to improve and be able to scale up the use of this device, so other people besides just one patient with a 3D printed piece could wind up having something that could be utilized in a similar manner. So over the course of the student semester, we worked back and forth, as these collaborations often happen between a clinician and a group of engineers. we worked together to figure out the best types of approaches, and we explored a whole bunch of different options. And as it turned out, there was a solution that we came up with that looked like it would be much less expensive, easily to customize, and would allow us to use this type of device not just for people in kind of well-resourced situations, but also in places like low and middle income countries, in places like the military, in places in the United States where there's difficult access to care, where patients actually might not have the option to either right away have the replacement of the bone where it had been, or to have actually any subsequent surgery at all. So that's where we kind of got to working so far, and we've submitted a patent application and have really been exploring ways that we can help the world by deploying this device in a variety of situations where it might be needed, most notably in, as per our discussion, in the military applications.
Yeah, that's an incredible experience, honestly, knowing from how the patient actually engaged with you and your team to lead to, the development of an idea is actually probably one of the unique aspects of being a physician inventor as opposed to an inventor in another industry, right? The people you're taking care of come to you. Obviously, you have much more experience than I do as a physician, but I'm sure you can attest to the fact that just when you think you've seen it all in medicine, somebody will sure enough walk through the door with something new, an old problem presented in an never before seen way. And that's exactly what you get as a physician inventor. As soon as a patient comes to you with a problem you've never encountered, you get to work with the patient to come up with a novel solution. And, that's a really cool story of how we got to this device. Now, there's a lot I want to unpack over the next hour or so that we have together in terms of actually, some of the military applications that you alluded to. I want to talk a little bit more about the actual process of, some of the players that got involved in the development of this device. And also, some of the conditions. We talked about your patient, right, who, had obviously, because it was infection that led to the needing to delay the reconstruction of her skull defect. But really, as you said, if you sit down and really think about where a device like this is applicable, there's a lot of areas we can. So I want to get into all of that. I want to actually look at the video where the audience can see what the device looks like. But first and foremost, I just want to pause for a second. Welcome everybody in the audience. Please, if you have any questions, go ahead for me, for Dr. P, put them in the chat. Let us know. And we're gonna talk to you about it. If you've ever had any form of brain surgery or neurosurgery, go ahead. Tell us put a 1 in the chat if you've ever had neurosurgery before. We want to know how many patients are out there to talk to. And while we take this break, I also want to mention, head on over to our YouTube channel right now, www.youtube.com/c/medical student neurosurgery training center. That is our URL for the time being. As a little update to sort of the Brain and Spine Group as a nonprofit organization, we are in the process, as we turn the calendar of 2023, really ramping up our investment in not just education, but research and public outreach. So you're going to see a lot less, I wouldn't say less. We're going to continue with all the same education we always do. We're not stopping that. But what you're going to see is a lot more new things coming out of Brain and Spine Group. And because of that, you might see the URL of our website change a little bit, some logo redesign happening. And what that's all designed for is really to capture the expanded vision and scope of what we're doing as a nonprofit organization. But what I want to ask you to do is head on over to our YouTube channel. If you're watching on Facebook, Twitch, wherever, and go ahead and hit that subscribe button. If you are really enthusiastic about what we're doing as a nonprofit organization, you can actually, just yesterday, we went live with paid subscription on YouTube. Okay, we are a nonprofit organization committed to free and open access to all of our content. We are steadfast in our commitment to not paywall or gate any of our content behind a paid subscription. A paid subscription just simply allows you to show off your support for Brain and Spine Group and also allow us to keep all this content free for those who don't have the means to pay to subscribe. So go ahead, $4.99 a month. You can become a paid subscriber of Brain and Spine Group and support not just education, but research and public engagement in terms of all things related to improving global brain and spine health. So after that little segue, let's go ahead and get right back into it. Let's start with the good stuff. I think people are really champing at the bit. They want to see what this device looks like. You mentioned, your patient was really invested in having a device that could be put inside of a wig, something that was aesthetically pleasing or could be made more aesthetically pleasing. I think, truthfully, nothing's more aesthetically pleasing than your own God-given noggin. It's a beautiful piece of hardware that God gave all of us. Sometimes it gets banged up, and we do the best we can to patch it back together. But so that being said, what I actually maybe more important than even looking at what you made is, why don't we look at what exists? Because I was looking through some pictures this morning, kind of thinking like, what's out there? Like, this is not the first time we've ever tried to create something, right? I mean, you've dealt with this, but what are some of the problems with the current things that exist? Why don't you talk about that while I go ahead and pull up some pictures for the audience so they can see what kind of things that we're stuck using for patients right now.
Well, we looked into all of this as part of the creative process of inventing this device, and really looked to see if there's even a need in the market for, having something like this. When we managed the case of this index patient, it was out of, this patient's particular need. But before we really engaged in the process of developing, as a biomedical engineering neurosurgical team, a product that might help people, we looked to see what was out there. And of course, the most commonly used device is a helmet. And the problem with that is that it is unwieldy, cosmetically unappealing. And it turns out that many patients don't actually use it. They're not compliant with it. And if the device is not used, it's not actually doing its job. And so that was really the most compelling reason why we sat down and worked on something that would be better. So the guy in your picture seems pretty happy, but that look is really not the same when you're out to dinner, at a party, as our patient was, and in many situations, in many countries, in many environments, it's actually not feasible to be wearing a device like this.
No, it's true. And I mean, here's another great picture I found that I thought you'd get a kick out of. How many patients have you seen that just look this content and happy wearing? These are what the helmets looked like in my hospital. So they didn't usually have that hard outer shell. They look pretty much just like this. I mean, how many patients look this content and happy wearing a helmet to protect their head? Not very many in my experience.
And the problem, therefore, is that the patient winds up not wearing it. And anything that you design for a patient has to keep in mind the actual patient needs. It certainly serves the function, but realistically, to expect a patient to wear this is really unfair and unrealistic.
No, I completely agree. And honestly, there's so many more reasons too. I mean, you've touched on sort of the aesthetic, the life to daily life functionality, but and honestly, I can understand how obviously you and I being in two different positions, right? You see patients primarily outpatient. You're dealing with much less. I mean, maybe correct me if I'm wrong. Do you deal too many patients on like an extended inpatient stay basis, or most of your patients
my specific surgical area, most of the patients are outpatients by design. But I do see patients in the hospital, and even in a hospital setting, a device like this helmet is hot. It's uncomfortable, and really in the short term is not really great. Even for from the perspective of wound healing, you have
that's what I was going to bring up.
Sweaty head underneath a unbreathable device.
Yep, and that's the problem that I encountered a lot. Being a physician who's taking care of patients solely inpatient, right? Primarily trauma was the root cause of the reason that led this patient to needing to have a helmet on. So very often, they're already struggling from meeting their daily needs of living, so they need assistance based on their injury. They just had a big surgery. Usually when you're dealing with trauma, there's a lot of reasons why they're at a higher risk for infection. When dealing with these types of patients, wound healing is probably one of the biggest threats to a patient's recovery when you're dealing with all these factors combined. And wound healing is horrible inside these devices, right? You can get life-saving intervention, basically have, just near dodged a bullet in life. You're recovering, and then the wound breaks down, it turns into an infection, and all of a sudden a patient's path of recovery just starts snowballing backwards. They start falling back down the mountain. And honestly, it's a struggle because you don't want to leave them just sitting in a hospital bed with nothing protecting their brain. But on the other hand, these helmets are a huge problem for wound healing. So that was, in my opinion, probably the most, or at least from my perspective as a clinician, the most exciting part about your device was that somebody is talking about the fact that the current standard is terrible for wound healing. So let's look at the actual device. I think it's a good time to actually kind of look at how you guys have changed these goofy standards and, actually created something in the process of creating something a little bit better. Let's see. Let's go ahead and let's get that pulled up. I know it's here somewhere.
And while you're pulling that, I will add that, part of the impetus behind this is that it's kind of a requirement to let some healing happen before you close the hole back up. Intuitively, you might say, well, then just put like the hole back in. But a lot of the situations that happen here that cause the patient to need the bone removed and left out, a lot of those situations by nature require time until a piece of bone is put back in there. So it's not just like in this patient's situation, she wanted to leave it out, even beyond when the surgery was scheduled to replace the defect inside. But in many situations, there may be increased risk of infection if you go in too soon to put the bone back. There may be swelling that's happened in the patient's brain that requires you to keep this piece of bone off to allow the brain some space to breathe inside of the head. So there's many reasons why it's important to actually let the hole be there for a longer period of time than one might imagine, so that there can be the appropriate time optimized to allow this cover to be then taken away, so that the recovery can happen and the piece of bone gets remanufactured or put back inside the patient's head.
Mm-hmm. Yeah, and especially in my world where I'm concerned about traumatic causes leading to this, there's very few traumas that are sterile, right? I mean, usually, especially military trauma, penetrating injury, and as soon as you have an environment that's not clean, I mean, the general belief, consensus, to the best of our understanding right now, is that waiting as long, a much longer period of time to put a patient's original bone back on, which is, for our audience that's not, they're not healthcare providers. When we put a patient's bone back on, we refer to that as a cranioplasty. That's a very fancy term. Probably sounds much fancier than it actually is in reality. And we're going to talk a little bit more about that later in the show. But, when that bone that you're putting back on, or the brain underneath, or the skin, is potentially compromised, could be heavily infected because of a trauma, a military injury, generally it's believed waiting a longer period of time to do that cranioplasty reduces their chances of the bone becoming infected and causing more problems. But like you said, right, delayed cranioplasty or waiting a long period of time to put that bone back on that's a longer period of time where their brain is vulnerable. And so I think we're finally at the moment where we're ready to take a look at the device. So this video I'm about to show you was put together by the biomedical engineering students at is it the Manning School of Biomedical Engineering, I believe it's called now, in Cornell, in Ithaca. Yeah, I think they renamed it shortly after I had left. I don't think it had a name. It was just the Biomedical Engineering School of Biomedical Engineering when I was there. But the students there have worked now, and several generations of students that have come and gone to work on this project. They've put together this video. It's a brief demonstration of their prototype. And what you'll see is basically the way this prototype is developed is to, one, demonstrate a device that's adaptable and is able to address this need for not hindering wound healing. And so let's go ahead and pull up the video. Let's take a quick look. So if you can imagine a helmet-like device or an insert to a wig, but you need that insert to be, let's go ahead and get this off the screen. You need that insert to be adaptable. Some patients may need it bigger. Some patients may need it smaller. And the way that they do that is by basically building a cranial helmet with Legos. And they've essentially made fancy Legos that are designed to create a breathable environment that allows for good wound healing. So that way you can create a device or a protection for a bone flap of different sizes to meet the needs of the patient. And so I think this is really cool. And I think you guys can, if I just offer my 2 cents on the design, I think you could even, break these down into possibly smaller pieces. If you had a perpendicular joint that allowed you to sort of build pieces not just out but also up, then you could really customize it for really any obscure experience that you come across with a patient. Because as we've alluded to, just when you think you've seen it all, somebody comes in with something new. So I'm going to run the video one more time. And go ahead, Dr. P.
Appreciate that design idea. Part of the fun of inventing medical devices is getting a lot of feedback from people both within and outside of the industries, as in outside of engineering, outside of medicine, and even just having feedback from patients themselves is really helpful. Industry can comment, intellectual property experts can comment, business people can comment. So it's really helpful and definitely serves to improve the invention process by being open-minded. When I came at this particular device, I had a very fixed idea of how this was going to work, with a 3D printed kind of looked like a little bowl almost that would cover the defect, but it was expensive. We had to use imaging, scans and computers and all sorts of stuff to make something. And we realized that in order to scale this up and help a lot of people at a low cost, we needed to make it much simpler. And neurosurgeons and engineers all love Legos. And so having something that's interlocked like this was really an appealing concept to us, so that we can customize it.
Okay, that's awesome. I mean, it's fun too, right? Because if you can imagine, there's nothing that gets planned from the very beginning. It just works out, right? Every step of the way, you sort of encounter new problems. So I kind of want to shift gears a little bit, but before we do that, I just want to go ahead and let everybody know that you can go ahead, when you get a second after watching this stream, you can head on over to brainandspinegroup.org/support if you want to support what we're doing. Brain and Spine Group's got a lot of great new stuff coming as we turn the calendar to 2023. Dr. P and I are, heavily invested in growing the research production and support that Brain and Spine Group does. So that way projects like this, projects like supporting veterans that we've had veterans on the show recently, all these things that really need to be supported in the world, Brain and Spine Group is committed to supporting them. So go ahead, head on over to brainandspinegroup.org/support if you'd like to support that mission. We've got really ambitious schedule for the upcoming year. We hope you'll consider partnering with us to support that. So let's get back into sort of more of the design questions, the process of designing, much more so than the actual device itself. I think, we've really sort of honed in on, your patient, their needs, some of the needs of a device like this, but just in general, right? Because you also, if I'm not mistaken, you have an adjunct appointment in the Department of Biomedical Engineering.
So that's correct.
So let's talk more about that in general, just inventing and biomedical engineering. What advice do you have for maybe a high school student who's watching, who's, curious about inventing things in medicine, or even a grad student who's in the middle of a biomedical engineering program and, wants to come up with that next big idea? I mean, let's just kind of talk about the process of inventing.
Sure. So my day job, my everyday job is I'm a neurosurgeon at Weill Cornell, New York Presbyterian Hospital, and I practice clinical neurosurgery and specifically radiosurgery, which is what you and I started this conversation talking about Gamma Knife. But beyond that, I have a faculty appointment, a kind of a secondary job in biomedical engineering at the main campus of our university, of Cornell University. Through that, I have the opportunity to really develop a environment, infrastructure to foster projects between clinicians, often neurosurgeons. We love devices, we love tools, we love inventing, and biomedical engineers. And what often happens is the clinician, in this, my own case, a neurosurgeon, but this can happen in any part of medicine. The clinician has a need. They come up with an idea, a need, not even necessarily thinking about an invention, but they have a desire to help human health in some way or another, often stemming from their experience with patients. And they think about what could happen, what they could do. And of course, they're not fully equipped in general to be able to solve that problem. On the other side, we have the engineers, often the biomedical engineers, who have lots of ideas, but needs to fill with those ideas. So when we sit down at the table together in conferences, in classes, in meetings, it's often a conversation of the clinician saying, wow, I have this problem, I really don't know how to fix it. And the engineer on the other side of the table saying, that's great, I totally have something that we can fix that with. This is an easy problem, I have an easy fix. And that's how that conversation starts. Similarly, the biomedical engineer may say, I have this great idea for a device, a product, a technique, whatever, but I'm not sure what we could do with it. Or they'll say, we know what to do, but we're not sure if it's actually applicable, clinically realistic. So they may say, we have this thing that it can do something. And the clinician on the other side will say, that's an amazing idea, but in reality, it will never work because of whatever. And the two of them, ultimately, it winds up being the lot of them, people on both sides of this team, coming up with something that actually has clinical applicability and solves a problem. So through these back and forth conversations, that's how a lot of these inventions, in my experience, happens. And from that organically arises a product that can help people.
Mm-hmm. Yeah. So I'll just take a quick pause there. So we got user Nordy Bebe in the Twitch chat saying, amazing stuff, Dr. P. How do you manage making a product that is functional but still affordable? And I think that's honestly a great question. Yep. Because affordability in the American healthcare system is always a question that patients are increasingly asking themselves.
Yep.
Is that something you think you really have to think about when you're creating devices?
So I think that's a fantastic question. And again, when we design something, when we invent something, often we don't really think about affordability, marketability, whether it's useful in being commercialized, whether it can actually be used in multiple places and not just in expensive healthcare environments. And we can do things like, we took out the 3D printer here as a necessary tool. This can be our particular device can be manufactured in a variety of ways, not just on a simple, desktop printer to scale it up and make it less expensive. You can decide to choose the materials that you create for, in this case and in others, what you make the product out of. You can figure out in your decisions about making the device out of stuff A or stuff B. You can choose B if it's less expensive, as long as it's equally safe, because obviously safety is always the most important consideration. But there are multiple ways that we can alter our initial concept in a purposeful way to make it affordable, and that way it will make it actually more practical on a global basis to encourage use and to make it actually useful in the market.
That's great. Yeah. And so actually, on the note of talking about creating medical inventions and affordability, I want to talk a little bit about, some of the applications of the device, because I think, conversations we've had in the past is the importance of creating an affordable device that's not just applicable here in the U.S., first world country healthcare, but really abroad where, aid in medical care is really needed. But before we get into that, I just want to take a pause, because obviously we've covered a lot of ground in a short period of time. We've had viewers coming in throughout, and they may not totally be up to speed about what we're talking about. So I just want to welcome all the new viewers as you come in to the stream. I'm Dr. Rad. I'm here joined by Dr. Pannullo from Weill Cornell. We're talking about a device that she and her team invented that is designed to basically protect the brain of patients who either had a trauma or other reason why they had to have a piece of bone from their skull removed and left off for a long period of time. She created a device that protects the brain while the skull is not in place. And what we're talking about is basically, we've talked how she developed the idea, worked with the team to create a prototype. We took a look at the prototype, and now we're sort of talking about how this, we foresee the device impacting not just, healthcare in the United States, but really abroad. So when we think about this device applied broadly outside, civilian, we'll just put civilian healthcare in the United States, right? Because that's sort of the world that you and I live and breathe and work in on a day-to-day basis, right? Outside the United States, you have the military operating, whether it's U.S. military or, other countries' military operating throughout the world. You have areas that we identify as sort of the public health domain as LMIC, low middle income countries, where basically, many of these countries, such as in Africa, where the mean population is very low income, very poor access to healthcare. And obviously, because of a lack of population health measures, even something as simple as wearing a helmet when you ride a motorcycle, right? It's not uncommon. You go to another country and you see people zooming up and down the road on motorcycles without helmets. It doesn't take a doctor to look at that situation and say, I bet they have a lot more head injury in that country. And the reality is they do. And they also have a lot less medical infrastructure to deal with those head injuries. So what kinds of things actually end up happening in these countries that your device that you've developed would actually probably apply very well for? I can speak a little bit to sort of the military applications as I see things, but why don't we just talk kind of more about that LMIC, that low middle income country, poor population of the world with high rates of head injuries?
So there's kind of two main categories of people that might have to have a piece of their skull removed. One major category is trauma, head trauma, and the brain swelling that occurs after that can cause a need for an emergency operation that is feasible to do in most trauma hospitals, and that is basically removing the bone that's constraining the brain inside the head to give it room to swell, and is often a life-saving procedure. When that happens, the bone is not left back on purpose to allow time for the brain swelling to occur and then to subside. A second common reason is strokes. There are some types of strokes that can cause a patient to need to have a piece of their skull removed, again, to allow for swelling. And then there's I guess really a third category, like we had talked about initially, where a patient has surgery, perhaps an infection, requiring the bone that was initially replaced to be then again removed. But I think for the purposes of the low and middle income countries, it's really the first two categories that are the most prevalent. So the reality is that the life-saving surgery in these cases might happen in the stroke, in the head trauma, where the piece of skull is removed. Again, it's not a very complicated surgery. However, in many, many cases, the patient is not then offered a second expensive operation to replace the piece of bone, either with the piece that was removed, if it's usable still, which in many cases it's not, or with an internal prosthesis, an internal molded object that's very expensive that gets put in to replace the missing piece of skull. So the reality is that in many countries, the patient's life will be saved. However, a second surgery to replace the piece of bone is not actually offered, and therefore you're left with a patient that looks like what Dr. Rad has put up in the screen.
Yeah, I believe this is from an academic journal, and it's the result. I believe they cited a bullet wound to the head. So this would be like your typical penetrating trauma injury. You know, obviously contaminated environment, big incentive to wait to put that bone back on. But for our audience, that are not physicians or healthcare providers, you know, a lot of this stuff we're talking about may sound very kind of pie in the sky. I don't really understand. How could somebody not have a bone on? What does that even look like? Well, this is what it looks like. And I remember the first time I ever saw a patient with basically coming in for cranioplasty, and you know, they looked very similar to this patient. I believe I was working for Dr. Notman at the time. I was an undergraduate student doing research, and he's like, go talk to this patient, see if they want to participate in our clinical trial. I was like, sure thing, Dr. Notman. Young, bright-eyed, bushy-tailed undergrad student. Walk over there, and I probably my eyes jumped out of my head. I was like, where's the other half of this person's skull? They were coming in for a cranioplasty that day. And so if I do apologize if you're seeing these images, you're like, oh, that's kind of disturbing. Yeah, it is. But sometimes the world of neurosurgery can be a little disturbing. You know, it's not a job.
It's disturbing for the patient also to have to be, seen in this way. And, you know, it's not such a great thing for them to have to be walking around with a helmet either.
Yeah, exactly. I mean, patients don't enjoy having their skull missing. They don't enjoy having to wear a helmet. You know, there's a lot of incentive to not just have a functional device, but also an aesthetically pleasing device. And I think it's a very worthy investment of your time and, you know, the time of your team and the institution to invest resources. It's really cool. We've got a question in the chat from Lana. She says, does the device have any way to negatively impact the skull? As in, like, can the device be misused? Were there instances when someone possibly misused the device? Can the device interfere with other treatments? So I'll give my perspective, and then we'll see what Dr. P has to say. Because the question that caught my eye is, can the device interfere with other treatments? I would say, honestly, no, because currently the current device, I should say it shouldn't, right? Current devices, the way they interfere with treatments is primarily, in my opinion, through wound healing. There are possibly some situations where if you needed to do a repeat surgery, some very niche situations where the device, like the existing device, could interfere with treatments. But I think if Dr. P and her team are successful in, you know, the final design of their device, right, their goal is to try to solve that problem. So that way, the primary interference that the current standard has, which is, you know, poor wound healing, and, you know, it in many ways almost promotes wound breakdown, If their device is successful in solving that problem, then I believe the answer would be no. The device should not interfere with other treatments. In fact, the customizability of the device may even facilitate things like better placements of surgical drains. That's a very small consideration, but something that might pop into my mind as an issue. But overall, no, I really don't. I can't. I mean, it's hard to say, right? You guys still need to test this clinically, right? You're still in a prototype phase. But in an ideal world, if you accomplish everything you've set out to accomplish, then the answer to these questions, at least in my perspective, would be no. You want to take a stab at it, Dr. P?
Well, I think that the question is a great question and is part of what the inventor thinks about when actualizing the creation of a medical device. Is the device must go through extensive testing, both in the lab and then ultimately clinically, where you see what types of situations might cause a problem, where you see if it would interfere. You hope going into it that there won't be any problems, but always with any type of medical advice, and part of the approval process that allows the medical device to be used in patients and sold, marketed, etc., is this extensive process of testing to ensure both effectiveness, that it's doing its job, and also safety, that you're not causing interference with other intended events in a patient's life.
That's great. Any follow-up questions to that? Go ahead and leave them in the chat. We are really excited about what this device could possibly mean. We're here to answer your questions. Please just put them in the chat, and we'll happily get to them as we get breaks. So we talked about the basically creating an affordable device that's not just going to solve a problem here in the United States, but be cheap to manufacture, able to export to low middle income countries. So that way patients who are able to get the life-saving surgery, but for a myriad of reasons cannot undergo immediate replacement of a bone, or possibly even, I got to imagine, I'm sure you really go out somewhere far in a low income country, they may take the bone off and the bone gets lost, and it doesn't get put in a freezer properly, and the patient just never has a bone to put back on. And if you're in a situation where that happens, and you're probably not in an environment where they're going to 3D print you a custom bone flap, you may just be stuck without a bone flap for the rest of your life. And wearing a foam helmet in the middle of a desert probably is not a great option. And so a device like this in that situation could be a very cheap solution to probably a situation that seems absurd in a wealthy environment that we live in, but probably not as absurd to people accustomed to these types of rigorous conditions in other countries. So let's talk about military applications. Because you think, okay, let's not even consider other countries' militaries. We're just talking about the U.S. military, keep things simple. You say, oh, this is one of the, most technologically advanced militaries in the world. They have all the money to do everything they'd ever want. Why would somebody not be able to just get a perfect 3D printed implant if, say their bone skull, the skull was just absolutely obliterated from some sort of penetrating trauma. You don't even have the original bone to put back on. The military's got all the resources in the world. Just print a new one. Why wouldn't you advocate for that versus the device that you guys, like, where does your device that you've created, fit into that model? We just want to welcome Kyle to the chat. It does sound like a great device. We appreciate your enthusiasm. Welcome to the chat. So anyway, go ahead. Why don't you tell us where your head's at in terms of where this device fits in with military applications?
So, of course, as a decorated veteran, you'll have much more up close and personal experience with these types of situations than I would. But my understanding is that there are many circumstances in which the initial surgery happens. Again, the life-saving surgery for a head trauma, closed head trauma, cracking the skull, any one of a number of things that cause a piece of skull to be removed, and then it's not feasible to do the replacement of the skull, either short term or even in the long term, while the soldier is out in the field, while the soldier is someplace where that
Marine or Marine.
or Marine, thank you, out in the water, wherever they in the sky, but the patient is in a situation where it's really not feasible to do the typical replacement of the missing piece of skull, either with the own piece of skull, again, if feasible, or with a internal device that could be utilized in normal circumstances. So, for example, it may take a while to get the patient to a tertiary center, a high-level center in near where they are injured, or back to the United States, to allow for that secondary surgery to occur. And in that entire time, the patient, the military person, is in jeopardy because they don't have the needed protection of their intracranial contents of their brain while that period is elapsing.
Yeah. So, and what you're getting at is basically, in a situation where a delayed cranioplasty is needed, something needs to fill in the gap. Sure, there's patient situations where, this may be a long-term solution. Actually, I'll tell you guys about a patient I took care of several months ago that I'll save that story for a minute. But basically, in terms of the military applications, when there's an indication for delaying cranioplasty, a device like this fits in very well to bridge that gap. And anytime where, as a trauma guy, anytime you have a contaminated surgical environment, delaying your cranioplasty is probably going to be the route you end up taking. Now, don't take it from me as an expert. I don't consider myself an expert. I'm here just diving into the world of, neurosurgery and brain and spine care, learning along the way. But, in a situation where you need a delayed cranioplasty and military applications, the data tells us that they have significantly higher rates of contaminated operative fields, not because of practice, by the surgeon. It's not like surgeons are, sloppy and contaminate their surgical fields. That's not what I mean. What I mean is when you're dealing with the types of injuries that they deal with, naturally the patient comes to you contaminated, right? There's nothing you can do about it. It's not a sterile field from the beginning, as opposed to, a fancy Upper East Side elective brain tumor surgeon. I don't know any of those. Their patients come in and, they get to do a nice, clean, perfect surgery. Meanwhile, the trauma surgeons, sending bullets down range and dealing with contaminated operative fields, right? In those situations, you generally want to wait to, do your cranioplasty. And that's where a device like this would be very, it's cheap, it's easily employed, presumably if you get the design just right, it will last a long time. And just fill that need. I mean, I'm excited to see kind of what happens in terms of military applications for the device. But as I was alluding to, before I get into this next story, I just want to welcome anyone new. I know we're covering a lot of ground. We got people coming into the show throughout. This is a really exciting device we talked about. What we've been talking about today are basically indications for delaying cranioplasty to repair skull defects. So any situation where a patient loses or is unable to have a part of their bone reattached to their skull, we need to still protect the brain in the interim. And what we're doing is sort of talking about this device that Dr. P's invented to help bridge that gap. And I remember actually, so when this is, I'm going to we'll go a little off script now, and I'll just sort of recap an interesting story I remember. And obviously, Dr. P is a very busy physician. Did you need to get off soon? Should we wrap things up, or how are we doing on time?
Good. I have a case at 12 o'clock, but we're good till then. I'm sorry, 1 o'clock our time.
1 o'clock. Okay, 1 o'clock Eastern. So we'll get Dr. P off the stream by 1 o'clock. I have a few things I'll sort of wrap up with before we close down for the day. But anyway, I remember when you first told me about this device. Admittedly, I was, I remember I heard your patient's story. I was like, okay, it makes perfect sense in that situation. But I remember thinking to myself, like, okay, like other than like this one obscure patient, who is going to benefit from a device like this? Just do the cranioplasty and be done with it. That's sort of like my initial thought. Maybe I was a little bit of a naysayer. That's fine. I remember this must have been a couple months ago. I had a patient came into the hospital for an elective cranioplasty. The patient was like mid-30s, obviously had, I believe had a prior trauma was the reason why they needed bone taken off of their skull, why their brain needed to be decompressed. And ultimately, once you do this type of procedure, you generally send the patient home and, they recover and they come back many months later to get the bone put back on. Well, the patient was finally sort of at this situation and, we apologize here. The patient was finally in this situation and they were coming in for what we call an elective procedure. For those of you who are not healthcare professionals, it basically means they didn't come through the emergency room, right? They went, they saw their doctor out in the office, they scheduled a procedure, and they came into the hospital for the day of the procedure. Now, you have to think generally like pretty healthy person. They had a prior trauma, right? This is not a 90-year-old person with like heart failure and lung problems and liver problems and all kinds of things. And this is somebody that you expect from the day of to walk into the hospital, get their procedure, spend a couple days recovering, and go home. Well, the patient comes in, they attempted to undergo the procedure. There was a complication with the procedure, and basically, I can't really get into the details of exactly what transpired, but this is a patient that for all intents and purposes, everyone expected to like walk in, get their procedure, and walk out. And for no fault of any of the physicians involved, the patient just didn't medically do well with the procedure. Unexpectedly, organ systems started to fail post-operatively. They, in order to make sure the heart, the lungs, the liver, everything was okay, they couldn't actually get the cranioplasty done. And, it became no longer a neurosurgical patient. It became a medical intensive care patient. The medical doctors were, suddenly, and there's no way to know if this was even remotely related to the surgery. The patient could have just been lucky to be in the hospital when he encountered this medical problem. But needless to say, we were not about to do a surgical procedure on a patient who suddenly developed all these other medical problems. And, you have to ask yourself, well, what's the long-term solution? You can't just leave this patient with their brain hanging out of their skull. And so I think I actually called Dr. P the next day or whenever I got off work, and I was like, that device that you were telling me about that I thought was kind of like an okay idea, but I didn't really understand it. I think I found the exact patient that needs your device. And from that, I've been a believer ever since. So with that story, I want to go ahead and just open up the chat for any last minute questions for Dr. P, any comments from Dr. P before she heads off to take care of her own patients. And then once Dr. Pannullo gets off the stream, I'll go ahead and wrap up with a couple other things that I've prepared, and then we'll call it a day. So the floor is yours, Dr. Pannullo.
I just want to thank you so much, Dr. Rad, for including me in this live stream. I think this is a great platform for learning. I think that what you're working on here and getting important information out into the world is really, really important. And I'm grateful for all your hard work on this. Thank you. I'm happy to come on again.
It's my sincere pleasure, but I can't take credit for anything but a small part of it. There's a huge team that does all of this. Carlos is a great producer. We've got a great content production team, tons of people that do stuff after the streams are over to make sure we're prepped for the next one. So really, my hat's off to the entire Brain Spine Group team because it really is a team effort that I can't take credit for. It's just an organization that I am very humbled that all the students and volunteers allowed me to lead them in. So we do have a final question in the chat from Kyle. He says, how can pre-meds or med students get involved in device design?
I can field that very quickly. Absolutely. So I think that if you can seek out a mentor that has a similar appetite for doing innovation, doing invention, asking around on your campus, either in an undergraduate situation or in a graduate school or medical school environment, you will see these people. There are often innovation centers and other types of platforms in a university environment where you can seek out collaborators. And I think if you come not seeking to hop on a train, but rather to come with your ideas and your interest and your concepts, that's really the way that you can be the most involved in device design to get people to help you achieve your goals.
That's great. That's great.
All right. Thank you so much for having me.
Have a great afternoon, Dr. Pannullo. I'm sure we'll talk soon. I believe we actually have a meeting with the device team this afternoon. So this conversation will continue off stream.
All right. Take care. Thanks, everybody.
Thanks for joining us.
Okay.
So that was quite a treat. I'm really glad we were able to actually talk about this device with Dr. P. There's, I think, some details about, trauma and the things that lead a patient to needing a device like this that just, in the interest of flow of the conversation that we didn't necessarily cover. But now we just have a little bit of time to cover a few things that might, I think are of interest to people. So we'll talk about that and then we'll wrap up for the day. But, really, this is, before I get into that, I just want to take a quick pause. I want to direct you all over to our YouTube channel. So you can go ahead and click the links if you're not already on YouTube. If you are already on YouTube, go ahead and hit that subscribe button for me. If you want to support Brain and Spine Group, we are a nonprofit organization. We rely on the support of our community to keep doing what we're doing. If you want to support the organization, go ahead and hit that subscribe. I believe the gold subscriber button. You can join our community on YouTube. It's a small subscription fee of $4.99 a month. It does not give any access to educational content that is not accessible to everyone. And you might be asking yourself, well, why am I subscribing? Well, it's because you want to support the nonprofit mission of Brain and Spine Group, which is to keep our content open and accessible to everyone, regardless of their means to pay. All right, we are on a mission to improve brain and spine health globally through education, bolstering research, and engaging the public on matters about brain and spine health. So if you can do that for me, head on over to YouTube, hit that subscribe button, join our community for $4.99 a month, and help support the mission of Brain and Spine Group. So let's get back into sort of the last bit of details. So I know we've talked about a lot about when you have a patient who, for this reason or that reason, and we've talked about various reasons. It could be a stroke. It could be trauma, as we've talked a lot about. It could be they had a prior brain surgery, but they got an infection after the brain surgery, and so they had to take part of the bone out, and they couldn't put it back in because that bone was infected, right? And so for a number of reasons, a patient may end up having, for a period of time, a part of their skull removed without the ability to put it back on. And so we've sort of talked kind of at that, like you have the bone off stage forward because we're talking about the device. What I wanted to do is I found a really nice medical illustration video on YouTube. As you'll see, It is copywritten by another organization or entity that created this video, rightfully so. This is not my property. I just thought it was a great illustration. I'm not taking credit for it. I just want to be able to show it as a really good illustration of how somebody goes from basically a skull intact to, after a trauma, having a part of their skull removed in order to allow the brain to swell. Because usually what happens after a trauma, after a stroke, after something that hurts the brain begins to swell. And as you can imagine, when you have a swelling brain inside a bony skull, right, the bone doesn't expand when the brain expands. What happens is the brain starts building up pressure. And that pressure then can start to cause the brain to die. And so the way that you keep the brain from dying when it swells is to remove large pieces of bone from the skull. So that way the brain can continue to swell outwards instead of being compressed within the skull itself. So let's go ahead. I'm going to pull up this video here and I'll sort of walk you guys through it. Again, this is a copywritten video. This is not my content, but it is free and openly accessible on YouTube. So for educational purposes, I have no reason to believe this is not fair game to share with you. What they're showing is a left, we call hemicraniectomy. Okay, I'm going to go ahead and just roll the video. We're going to click through. I'm not going to go through everything. So what they start here, right, they basically map out where they want their incision. This is what we typically call reverse question mark incision. As you can see, starting over here, drawing a line back, it creates this reverse question mark outline. And that's how they'll make their incision. And so we'll go ahead and watch here. Once they make that skin incision, they reflect the skin down towards the front of the face. And that skin flap comes with the temporalis muscle. That's that big muscle. When you clench your jaw, you feel it along the sides of your face. And this is how you expose the actual bone of the skull itself. Now, what they're doing is they're taking a surgical drill, and they're going to drill some holes in the skull itself. And so this is what we call burr holes. They drill these burr holes in order to get inside the actual skull. And they're going to drill several of them all around the actual exposed field. We'll go ahead and speed up a little bit. So now you've got burr holes drilled all around the surgical field. And what they're going to do is basically connect those burr holes in order to create a bone flap. So this is like a, the simplest way to put it is you got to imagine a little L-shaped foot on the bottom that runs along the surface of the brain, and then a little bit that drills the bone out in between. So you're protecting the brain with the foot plate on the bottom of the drill, and now you create your bone flap. And then the bone flap comes off. This is the most important piece of the puzzle, right? Missing this bone flap is the very reason, the purpose for the device. This device that Dr. Pannullo has created is intended to protect the brain while this bone flap is no longer present. And so once, for the many reasons we've discussed, you can't always put this bone flap back onto a patient's brain. And so we'll go ahead and roll it forward as we get into, now they're going to start getting into some of the more nitty-gritty details. And actually, we may just sort of wrap things up here. But basically, now what you've done is as you remove this bone, and you remove any blood or clots that may be existing on the surface of the brain, you've opened the dura, which is the covering of the brain. So now the brain's able to expand. It's able to breathe. It's no longer under such pressure. I'm going to go ahead and speed up. You wash everything out with irrigation. You're going to get all, assuming this is a trauma, you want to get antibiotic irrigation and clean it all out. Then what you're going to do is go ahead and leave a small surgical drain behind. That way, after you close all this up, you have a place where, blood and irrigation fluid and all the things that would cause the brain to be under pressure have a way to escape out of the surgical incision area. And then once you do that, you sort of put, we use lots of synthetic material to cover up that area where we opened the dura, the covering of the brain. And with that, this synthetic material covering, sort of serving as a barrier between the brain and the skin that's still reflected down, you're able to then bring the skin and everything back up. And then we sew everything closed or use surgical staples. And basically what happens is once it's closed, you really can't even tell that a patient had, other than obviously the incision and the external, their head will look relatively symmetric, because where that bone was taken off, that swelling brain is basically propping up the skin flap, so that way their head looks round and semi-symmetric. However, we'll go ahead and stop the screen share here. However, over time, as the swelling of the brain comes down, that skin overlying the brain will start to sag down. And that's how you know a patient is starting to recover. The swelling of their brain is starting to go down. And once that skin flap sags enough, that's generally when you want to go back and put the bone that was taken off and left off. You want to put that bone back on, or in some cases, you'll do a 3D printed prosthetic. You can get a CAT scan done of someone's head, and that CAT scan can be reconstructed and sent to a biomedical device company, and they'll print out of various polymer materials. They'll print a custom fit replacement bone, and then you can do a surgery and you can put that prosthetic in. And generally, that's how a patient goes from having their bone removed to the period of time where the bone is just left off, to the period of time where hopefully they get the bone or a prosthetic put back on. And so what Dr. Pannullo's device does is really aims at addressing that period of time where the bone has to be left off. And for many of the reasons we've discussed, especially in the setting of, high concern for contamination or infection, leaving that bone off longer and allowing the patient's body to heal and clear out the infection, helps the patient ultimately do better. Because what you don't want to happen is to take the patient back for another surgery, put that bone back on, and then ultimately, the patient ends up getting an infection then from the second surgery. That just causes a whole new host of problems that didn't necessarily have to exist. So you usually want to make safe measure, be as safe as possible to try to avoid that outcome for a patient. And so I hope that, through today's live stream, we've been able to, show you all a little bit of a glimpse inside what it's like as a physician to have a patient come to you with a unique problem. A patient to say, I need, X, Y, and Z as my doctor. Can you help me figure that out? And the doctor, you say, well, nobody's actually encountered this problem before. This is something new. And using your resources as a physician at an academic institution to collaborate and work with engineers and other physicians with ideas and enterprise personnel. You bring all these minds together to create a solution to a problem that a patient presents to you. And then in Dr. P's situation, you end up creating a new device that you can then patent and create prototypes with. And, hopefully, we wish the Cornell development team the best in their future of this device. We hope that they really work the kinks out and get the, device functioning smoothly, make it very adaptable. They get good clinical data to show that it actually does meet their endpoint of facilitating better wound healing compared to the current helmets, which, personally, I think is a huge problem. There's a lot of steps that go into device development, and while where their device is at is, it's very exciting, they have a prototype, there's still a lot to do. And, we're definitely eager to sort of see how things pan out going forward for that device. So I just want to, as we sort of wrap up, any last minute questions, comments? I just want to check in with everybody viewing out there. Please go ahead and hit us up in the chat if you have any questions. I want a chance to answer them before, as we sort of wind down on today's stream. If you've got any ideas, things that you think would be great ideas for devices, tell us about them in the chat. We got a few minutes. We can talk about them. We can brainstorm together. This is the important thing for live streaming for Brain and Spine Group. This is not an endeavor that we sought to start as a purely one-way dialogue where somebody sits up here live streaming to tell you about their expertise and blah, 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 blah. I've said this since the first stream. I don't consider myself an expert. What I consider myself is an enthusiast, not an expert. I'm very enthused. I enjoy all aspects of neurotrauma. People have said to me, because you're going to encounter naysayers at every phase of your life, oh, you just like neurotrauma because of, it seems very exciting and you're not very experienced. No, I'm not. Neurotrauma doesn't excite me because they're exciting procedures early on in your career. Neurotrauma excites me because of the potential for research. I got into brain and spine care because of my experience in the Marine Corps, in the combat zone, seeing people undergoing head injuries. In my personal life, seeing a close friend undergo a spinal cord injury while out doing sports with myself. We were doing, I don't want to get into the details. It's his personal life. I'm not, here to put that out there on a live stream for him. We were just out doing some extreme sporting activities, and a freak accident changed his life in a moment. And, seeing these experiences in my life have made me want to not just become an expert in neurotrauma, but I'm enthused by the research, by trying to make, a dent in this colossal issue of the world, right? Fixing neurotrauma is like trying to eat an entire cow in one bite, right? You're not going to do it. But if anybody refuses to take a bite out of the steak, you're never gonna tackle the problem. And that's my goal as the director of Brain and Spine Group, in my own personal academic endeavors, my own clinical endeavors. I want to make a dent in neurotrauma, in TBI, in spinal cord injury, and there's many ways we're doing it. I'm really, I love working on papers and manuscripts with students and faculty. We have some really exciting stuff. We just had 3 abstracts accepted for the National Neurotrauma. One focused on looking at treatment options for veterans in TBI. The other looking at incidences of pediatric TBI and how it affects incarceration rates as adults. There's a lot of interesting things to explore in neurotrauma. And I love what we're doing with Brain and Spine Group because we get to start, we either tackle the problem directly or we use our resources to support somebody like Dr. Pannullo and, their team at Cornell University trying to tackle a problem. It doesn't matter. Nobody here at Brain and Spine Group is in the business for their own personal gain or their own personal ego. That's why we operate as a nonprofit organization, because we're in it for making the world a better place in terms of brain and spine health and doing the right thing, right? If we wanted to, tout our egos and collect a paycheck from all this, we probably wouldn't be in the nonprofit business. We got a question in the chat from Lana Aldos. She says, how often are live streams? Well, as of right now, we're live every Tuesday and Thursday at 12 noon. We generally stream probably for, 90 minutes to 2 hours. There's no set end time. It's really about, engaging in a topic for the day. Some will be longer, some will be shorter. My hope is that as we continue to expand our reach and our collaborations, which is expanding daily, we will come up with some new ideas for new shows. You know, my show, my live stream on BSG Live is really about the things that interest me in brain and spine health. But obviously, there's tons of facets to brain and spine health that don't fall in line with my personal interests or academic endeavors, and that's where I hope to see, shows hosted by other physicians or enthusiasts about different topics, whether it's brain tumors, public health, hospital systems, things. There's a lot to talk about in terms of making the world a better place for brain and spine health. And as long as it's a noble cause, we're going to support it as a nonprofit organization. That's my philosophy from the top down. And so obviously I've sort of rambled on a little bit here at the end, but that's the joy of doing this as a free-form live stream. I get to know you as the audience. You develop your own sort of personality as we interact in the chat. You get to know a little bit more about me, and that's why I think it's fun to take these times outside the sort of pre-planned material to talk a little more on a personal level. And we got Kyle in the chat. He says it would be interesting to see if this device can decrease rates of Treffind syndrome. Yeah, it's a great clinical question. For those of you who are not healthcare providers, Treffind syndrome is a clinical syndrome, meaning it's not a concrete diagnosis. It's a more of a constellation of symptoms that is related to having bone removed from someone's skull. We don't entirely understand the biomedicine, the actual biology that leads to developing a constellation of symptoms that's typically considered to fall in line with this syndrome. It's hypothesized it's related to CSF dynamics. CSF, as a reminder for those of you who don't know, stands for cerebrospinal fluid. CSF we talked about, I think, first week. That's the fluid that sits inside your brain and spine and basically creates a cushion of fluid that the brain and spine sort of easily floats in. That way, as you're walking around day to day, doing all the things that you do as a person, you jump up and down, right? When you jump and you fall back down to earth, your brain doesn't slam around inside your skull. You'd have a lot more head injury if that was the case, right? Your brain and your spine, it floats around in a pocket of fluid called CSF, cerebrospinal fluid. And so usually when you remove bone from a patient's skull, the dynamics of how CSF flows through the brain, pulses through the brain, because it has a very pulsatile nature, it changes. And there's thoughts that removing the bone can mess with CSF flow. That could possibly be related to some of the symptoms that are encountered. And so what Kyle in the chat is alluding to is questioning clinically, right? Because eventually you take a device after you've created it, you have to ask yourself a bunch of clinical questions and explore those clinical questions. The first and foremost being, is this safe for patients? And that's where you start getting into the different phases of clinical trialing, which we'll save for another time. But in general, right, you first and foremost want to establish that a new device is safe for patients. That, if you expand your clinical exploration of the device in more and more patients, you're not going to end up hurting patients because you forgot to check if it was safe before you start asking questions like, does it make their headaches better? Does it make, wound healing better? Right? These are secondary questions that come after the primary question of whether or not something is safe. And so, yeah, that's a great question, clinical question to explore in subsequent trialing of a device like this. And so, I've really enjoyed this time sort of at the end of the stream. On more of a personal note, I really hope that you all are enjoying these live streams If you have ideas for topics you want to cover, you can email your ideas to stream@brainandspinegroup.org. Myself and every member of my team reads every single email that comes through. So we will absolutely consider that idea. If you do send us an idea, and even if you don't hear from us right away regarding it, it may just be because we need to find a good spot in the calendar, right? We're doing the best we can to really plan the concepts for the streams out in advance. We've got a lot of really great stuff coming down the pipeline. I think we're going to spend a lot of time for the rest of this year up until talking, I would say, probably adjacent to traumatic brain injury topics. We'll sprinkle in some spinal cord injury as I get some guests and enthusiasts. We'll try to refrain from using the term expert on stream because, frankly, expert is, yeah, sure, maybe it makes somebody feel good that they're talking to an expert, but the reality is somebody who's enthusiastic about something is probably going to teach you more than somebody who is an expert. That's my personal experience, because passion is what really pushes people through the grind. And so we're going to sprinkle in some spinal cord injury stuff as we get on, maybe before the end of the year. We'll definitely get into it more over the next year. I'm hearing a lot of viewers saying they really want to talk more about sports-related head injuries. So barring a last-minute change of the schedule, my plan for Thursday at noon, we're going to kind of revisit the concept of concussion protocols in sports, but we're going to look at it more from an MMA, boxing, and military protocols. Because actually, like I said, I do a lot of this research because I'm not an expert, I'm an enthusiast. And as I've been reading more about concussion protocols, the things I've really enjoyed looking into UFC, MMA concussion protocols, the military's concussion protocols, how they relate to this in-depth NFL concussion protocol we spent time looking at last week. And so we'll sort of as of right now, my plan is to come back to all that on Thursday, barring an exciting guest confirming that they can join us for Thursday. We may do a last-minute change of the schedule. But again, as the year goes on and we really iron out the details of streaming, hopefully we'll be able to sort of announce our guests and all that kind of stuff a little further in advance for you all. But there's really a lot of exciting stuff. My good friend Lewis is coming up. He's going to be on stream soon. And, he's a 20-year retiree, the United States Marine Corps, multiple combat deployments. We're going to talk about PTSD and the VA healthcare system and sort of what that experience has been like for him. And I think that's going to be a really exciting stream. We're going to conclude the year with one of my favorite stream topics. Although, I shouldn't say my favorite stream topic, but I think we came up with a great name for the stream. Our last stream of the year is going to conclude with Happy Brawladays. Okay, we're going to talk about head injuries in professional wrestling, the WWE. So I think we've got a couple WWE professional wrestling enthusiasts that are going to join us for that stream. You're not going to want to miss that one. That's going to be December 20th. So a little bit of a glimpse of what's ahead. It's exciting. I really hope you guys stay with us. Every Tuesday and Thursday at 12 noon. The whole organization's excited about what we're doing. And again, everything comes down to making the future better. Donating, subscribing, everything. It supports not just education, it supports research, it supports our public engagement. So please, I really hope that as the end of the year is coming, we are looking to get rid of those last minute tax deductions or whatever you need to do. Consider supporting Brain and Spine Group. You can do that through subscription to our YouTube channel on our YouTube page. You can do it through direct donation at brainandspinegroup.org/support. Thank you so much for tuning in with me today. And Dr. Pannullo, it was really a pleasure talking with all of you. We wish you a great afternoon, and we hope you come back and join us Thursday at noon. We're going to be talking more about UFC, MMA, and military concussion protocols. So with that, Thank you so much. We had a blast here on BSG Live on Tuesday. Please join us Thursday, 12 noon Eastern.